Hello, everyone. Just give us a couple minutes before we start. We're seeing the number of participants are climbing up, so it'll take a bit of time for people to join. Thank you so much for being here today. Okay, good morning, good afternoon, and good evening, everyone. Thank you for joining us from all over the world and for being part of this timely and urgent conversation. I'm Dr. Thoai Ngo. I'm the chair of the Population and Family Health Department at Columbia University. Before I begin, I want to express my deep gratitude to our faculty, staff, and extraordinary partners, HIAS in Colombia, the Policy and Strategy Group in Kenya, as well as CREPA in Nepal, who have really stepped beyond their daily work life during a very stressful time in global health and development to join us in this collaborative effort. And you see today their work had helped capture the full weight of the recent U.S. foreign aid cuts and its far-reaching consequences. So in late January of this year, the United States institute what called first frame as a temporary funding freeze, but what began as a pause now have become a near total erasure, unpending decades of progress and severing critical lifelines for millions. Today marks approximately 100 days since that decision. 100 days that have shaken global health system, stalled critical health and development programs on the ground, and exposed the fragility of international collaboration. And it's also clear that the United States is no longer a reliable partner in global health and development. So we gather here today not only to reflect, but also to bear witness through data and through evidence and through voices from the ground. So I'm truly thankful to our partner from the three countries who are joining us today. And since 1933, a US president's first 100 days has symbolized bold direction and policy intent. Today, we use that milestone to account for what has been lost, lives, systems, and communities. And because policy is just not policy on paper, they are deeply human. As you'll hear today, the consequences are mounting. Essential services are vanishing. More families are being pushed into poverty. Preventable deaths are on the rise. And history have taught us that vulnerable communities are often overlooked in time of crises. So we're going to help center their lived experience through data and evidence today. And even in the face of all these challenges, I'm heartened by our global colleagues who have adapted quite quickly. Many held the line, trying to find new ways to serve communities and to imagine the path forward. And so in today's conversation, we'll explore those possibilities, new innovation, new partnership, and resilience in a world that demands so much more of us now in a resource-constrained environment. And our sector had mobilized really quickly, tracking funding mechanism, tracking the health impacts, and documenting job losses. So where do we stand today? By the end of April this year, Stand Up for Aid, our colleague there have reported that 83% of the some 6,000 programs that were previously supported by U.S. foreign assistance have been terminated. The United Nations Office for the Coordination of Humanitarian Affairs, or OCHA, estimate that 79 million people are no longer receiving life-saving aid. These include emergency ration, HIV treatment, therapeutic feeding for malnourished children, vaccine, and clean water, basic necessity that many of us take for granted. And the impact metric dashboard estimate that 100 people are dying every hour as a direct result of this abrupt termination of funding cut. So at Columbia University, the Global Health Action and Evidence Program was created to advance global health through timely research and international collaboration. So when we first hear signs of USAID being dismantled, we mobilize our student, our faculty, our staff, as well as our partner across Colombia, Nepal, and Kenya under the GHAE initiative to conduct real-time research and to monitor the effects as they unfolded. And today we'll share findings on the sector-wide impact alongside country case study conducted in collaboration with our partner on the ground. And then we'll move into moderated discussion where we'll open space for shared dialogue, solution, and reflection of the findings. So thanks again for joining us today. And I have the privilege of moderating this diverse group of panelists who I really think embody the spirit and the strength of global health collaboration. Together, they bring deep expertise and frontline experience in humanitarian, in public health, and in development. So welcome Dr. Sarah Casey. She's an assistant professor in the Department of Population and Family Health at Columbia University. She also directs the Race Initiative. Joining us from Colombia is Camilo Ramirez, Country Director of HIAS. We're also joined by Julia Kosgei, Director of the Policy Strategy Group based in Kenya. And from Nepal, we welcome Dr. Anand Taman, Founding Director of CREPA. And we're pleased to also have Dr. Corinne Karima, Founder and CEO of Africa Kwanzaa Health Impact, a global health expert who specializes in malaria control. So without further ado, I invite Sarah to start the presentation. Welcome, Sarah.
Thank you, Thoai. So our goal was to, when this all occurred, was to empower our partners and provide evidence to donors, policymakers, practitioners, and researchers to develop evidence-based actions and investment in an era of shifting priorities. Next slide, please. So to support these efforts, we've been gathering and analyzing information kind of through three key streams. So an online survey with global partners, which is what I will be focusing on today, country-specific case studies with partners on the ground in Colombia, Kenya, and Nepal, who you'll hear from next, as well as sort of integrating and pulling together insights from reports and analyses with other partners. Next, please. So we conducted an online survey that we sent to colleagues around the world who were directly or indirectly affected by the US government funding changes. Our survey launched on February 10th, and sort of most respondents completed it during that first month. We noticed there was a lot of response fatigue, sort of the longer it was out there, as many other partners also launched similar efforts. The survey was available in English, French, and Spanish, and we had 103 people who completed the full survey. Next, please. So almost half of respondents were based in North America, but you can see they were spread throughout the world. And then their organizations worked pretty much globally around the world. Next, please. We could see that about half of respondents were from NGOs, either international or local NGOs, as well as from various other actors in the global health sector. Next, please. So we wanted to note that, the funding cuts and funding freezes didn't only impact service delivery, but also other areas like capacity building and health system strengthening as well. Next. And, services, we see an impact across various health sectors. In some ways, this may reflect PopFam's networks and that we had large percentages who referred to disruptions to humanitarian and emergency response, mental health and psychosocial support, gender-based violence, and other SRH services. Next. And then kind of take you a step back. We asked respondents to list the top 3 global health risks of the funding cuts. And we can see the kind of lack of access to services and disruption to service delivery was the most anticipated outcome of the funding cuts. Now we're going to dive into, what the impact on services is like on the ground in the 3 countries that we are working with. So our partners in the 3 countries conducted key informant interviews with NGO or community-based organization staff, with health workers, with community health workers, and government stakeholders. And as you can see from the table, these are countries that experienced substantial cuts to their US government funding, ranging from almost half in Kenya to all of Nepal's funding, US funding. So I just wanted to pass it over to dive into our country studies. Thank you.
Thank you so much, Sarah, for the introduction, and thank you for Columbia University for inviting us to be part of this webinar. I'm Camilo Ramirez. I'm the country director for HIAS in Colombia, and I want just to share with you some of the impacts and reflections about the cuts and freeze from the United States government a few months ago. Next one, please. But currently, we as a HIAS, we have the mission in Colombia since 2019, but we are an organization for more than 120 years based in Silver Spring in Maryland. Our main mission is to protect the most vulnerable people and supporting them to rebuild their lives, specifically refugees and migrants. We also have been working with people, our people of interest is related with the people affected by any type of conflict, violence, and also Colombian returnees in host communities. And we have like 4 main different signature approaches. The first one is related with mental health and psychosocial support. The second one is gender-based violence prevention and mitigation. The third one is economical inclusion, and the last one is legal protection. Currently, we have around 10 offices around the country. Next one, please. Well, in terms of a humanitarian context in Colombia, I want to just to highlight some specific topics related with this. Is Colombia is one of the largest host countries of displaced and migrant population. Currently, we are hosting a bit more than 7 million of internal displaced people, and also we have informal figures and figures that people as part of the NGOs are working as related about 3 million of refugees in Colombia. Currently, we have around we have a huge humanitarian infrastructure and architecture in Colombia, where we have more than 80 NGOs between national and international NGOs, and also we have almost all the UN agencies working in Colombia. In 2024, around 385 million of dollars were funded for Colombia, and 41%, almost 42% of these comes for the humanitarian response in the country. And according to the Humanitarian Forum, around of all of this, the 41% that comes for the humanitarian assistance, 70% of that amount or that percentage comes from the US government. This is an important fact related that with the freeze and afterwards, the cuts from the United States reflects the massive impact on the population and the humanitarian assistance in Colombia. Next one, please. Well, related with the information that Sarah was sharing with you and the survey methods what we use here in Colombia, basically we have like 9 interviews with humanitarian workers at the national level. Also, we have 9 interviews for humanitarian workers at the field level, mainly in the Darien Gap, which is one of the areas mostly affected by the people who's trying to cross the Darien and trying to just to arrive to the US, and also the ones who are in the reverse movement. And also we carry out around 16 interviews and focus group discussions with refugees and migrants to obtain this information. Just going to details, basically, the most affected departments or states, as we call in Colombia, departments, is Norte de Santander, Arauca, Cauca, and Nariño, who have the massive and the highest rates of displacement and violence, and this is being really impacted by the US cuts. Around 1.7 million of people will no longer receive any humanitarian assistance, basically because since January, with all of these cuts, we start to receive the letters from the United States. Basically, we have to stop almost all operations. This is also impacting almost all NGOs. In most of the cases, as the case of Hayas, we have to reduce our operation at least on 65%, and we have to close around 4 offices. And this is not exclusively for us. This is also a sector situation where most of the organizations will have some kind of dependency in the US funding. We have to take so dramatic decisions trying to guarantee that we are maintaining our operation and trying to maintain the response to the most vulnerable people. We are now being impacted with a new type of context, which is related with the reversal movement of the people, the ones who try to achieve the US, try to arrive to the border, and basically, unfortunately, they cannot continue their trip, and they have to decide to come back to their countries, and basically they are using the same route through the Darien Gap for another type of reusing the boats to try to just arrive from Panama to Colombia. And basically what we are finding there is that there is no organizations providing assistance on that reversal movement. Unfortunately, in the Darien Gap, for example, given that you around 15 to 16 organizations we were working before the cuts, and now no more than 6 or 7 are now keep working there with a smaller operation, resizing their operation, and at least cutting their staff in around 50% of the previous number they had before the cuts. This reverse movement, it's increasing. We are facing like around from 150 to 200 people arriving every day from Capurganá, which is the border between Colombia and Panama, and then to arrive to one of the municipalities in Necoclí and Turbo, trying to come back using 3 type of routes. One of those is trying to come back to Venezuela, the other one trying to stay in Colombia, and the other ones they want to just continue the trip to the south of the continent. Next one, please. As I was mentioned before, we are losing a lot of essential services, and mainly in terms of health and protection services for migrants. We're now anymore in the capacity to provide assistance to all municipalities where we're providing previously. This is also happening to most of the organizations. And the situation for the people which is still in transit, it's really complicated. One of the things we just to realize is when we have this type of interviews with the people, they're keeping transit on the reversal movement. One of them, or some of them, decided that when they was trying to just to reach the US, when we passed through Colombia, they realized there was a massive humanitarian infrastructure and architecture to respond to those needs. But now they're coming back, they are not finding the same that they found when they crossed initially, and we are facing a massive number of gaps to protect the people who are now in the same transit. In terms of needs of psychological support and psychological confinement, we are just facing that most of the people just to realize that they are not finding any type of support. Unfortunately, mental health is not something that for some people it's critical. Unfortunately, this is not a life-saving activity as was described previously. And we are not finding in the local capacity or in the local organizations this capacity to maintain the mental health and psychosocial support that most of the NGOs, international NGOs, were providing previously. Next one, please. In terms of the impact to the humanitarian infrastructure, it is clear that there is some regions that we are not finding any type of assistance, as the Caribbean coast, where the humanitarian transportation or the temporary shelters that were working before, they're not working anymore. We are facing a lot of challenges to maintain the coordination mechanism, as I was described before. We also have like two different mechanisms here in Colombia. One is related with OCHA as the humanitarian mechanism, and the other one related with the migration that was managed by IOM and UNHCR. But in both cases, we are not finding the same capacity to guarantee the full humanitarian coordination. And we are now trying to coming back to the previous moments, we were trying to coordinate between us. But it's hard whether you have a previous and a massive coordination mechanism. We are not finding the same capacity to guarantee they are providing the right services to the people in most of the locations. Next one, please. Well, one of the most important aspects that we found, it's about what is happening with the humanitarian workers. In my case, they have been working in this sector for almost a bit more than 20 years. This is the first time that I to face this type of situation. And I know that for most of my colleagues who have been humanitarian workers for all of our life, it's hard to identify that this is happening to us. And there's a massive feelings related with helplessness, frustration, and grief from the humanitarian workers. Also, there's a lot of demoralization, and basically the level of stress and anxiety increase dramatically. As I was mentioned, most of the organizations have to reduce the number of staff. We had massive layoffs in January, February, March, and some of them will continue up to the end of this fiscal year. There is a kind of, in terms of good news about this, is some of the grants funded by PRM in USA were resumed, they were reactivated a few weeks ago, but up to the end of the fiscal year, which means that maybe we can have some kind of capacity up to the end of the fiscal year in terms of the humanitarian sector. But this is just for a few more months, and also trying to just reactivate when you close almost everything a few weeks ago. It was be complicated to maintain or to reactivate the operation as it was happening before. Next one, please. And well, and personally, and as a humanitarian worker, this is one of the most critical aspects, and it's related how we are providing assistance to the people who's now coming back from Mexico, from Central America. And basically, there is a increasing number of people who have a lot of feelings related with demoralization. They feel a lot of frustration, and also most of the people who have had to face a lot of really complicated and not acceptable treatment in the US or Mexico related with had been detained or deported, or even they were victims of any type of violence. We are trying to guarantee some kind of physical assistance for them, mainly in the borders where they are arriving. This is in the case of the Daring Gap. But what I want to highlight here is and I was mentioned a few days ago in an interview with one of the newspapers in Spain, is the crisis is now, it's a new crisis, because when we have a crisis before and we try to thanks to the US government funding, we are trying to respond to that crisis and trying to provide some kind of capacity and assistance to the people who want to stay in this country. But now we have a new type of crisis because we are now facing a new movement of people who are now coming back with additional type of mental and mental health affectations that we are not in full capacity to respond, taking into consideration that we have to resize our operation in Colombia. Next. Thank you so much. I will pass to Julia.
Thank you, Camila.
Please, yeah.
I'm Julia Kosgei from Policy Strategy. Thank you, Thoai. Thank you, Sarah, for the invitation to share our findings on the consequences of the US foreign aid freeze on the Kenyan health system. The decision to suspend and ultimately terminate this support has destabilized critical health service delivery, undermined hard-won public health progress, and triggered a humanitarian fallout with acute consequences for women, youth, and marginalized populations. I will share what we are seeing on the ground, what this policy shift has meant for our healthcare workforce, for patients living with HIV, for young women seeking reproductive care, and for the broader health infrastructure under strain. Next slide. For decades, Kenya's health sector has depended significantly on external support. Sarah had already mentioned this, approximately 850 million in annual US aid, half of which directly funded health, has functioned as a stabilizing force in HIV treatment, maternal health, and family planning. The abrupt halt of about $220 million in health funding cut off a lifeline for thousands of clinics and programs. Over 40,000 health workers, many working in HIV prevention, community health, were placed on unpaid leave without warning. What this decision exposed is the structural fragility of a system that is dependent on external funding and the absence of emergency buffers to absorb such a shock. Next slide. Following the freeze, health facilities across Kenya closed, scaled down, or became effectively non-operational. Programs offering HIV screening, antiretroviral treatment, and prevention of mother-to-child transmission were amongst the first to experience disruption. In one of the counties in Kenya called Nakuru, over 43,000 pregnant women are at risk to lose access to PMTCT services. Clinics that served as essential sites for youth-friendly care, contraceptives, and post-rape services were forced to ration or halt services entirely. Consequently, patients are at heightened risk of morbidity and death, and health workers are left struggling to reconcile their duty of care with system failures. Next slide. The health workforce has been one of the most visible casualties of the freeze. Thousands of jobs are now at risk. Remaining staff face salary reductions, heavy workload, and growing psychological pressure. We've documented cases of acute mental health distress amongst affected personnel. One health worker previously employed by a USAID partner attempted suicide after losing his position. And the most marginalized groups have borne the brunt of this collapse. LGBTQ plus individuals, sex workers, adolescent girls, and low-income mothers have lost access to life-sustaining services. Next slide. Services such as PrEP, emergency contraception, comprehensive sexuality education, and safe abortion care have been curtailed. In many communities, private providers have withdrawn entirely out of fear of regulatory reprisal or reputational risk. Healthcare providers reported also an erosion of trust and growing sense of abandonment amongst these populations who had begun to rely on a more inclusive health ecosystem. Next slide, please. Adolescent girls have lost, from our findings, adolescent girls have lost access to family planning and sexual and reproductive health and rights services. This has increased their risk of early pregnancy, school dropouts, and LGBTQ plus individuals and sex workers who previously accessed discrete donor-supported clinics reported that both the loss of these services and heightened stigma within public, both loss of services and heightened stigma within public facilities. These groups now are facing dual exclusion, first from targeted programs and now from mainstream care. Healthcare providers have also mentioned that that resulting vacuum has forced some patients to sell their assets, to drop out of school, and some even to migrate to search for care. Next slide. Over the years, our country, Kenya, has achieved very significant progress in HIV prevention, maternal survival, and disease surveillance. But these gains are now at risk of unraveling. Interruptions in treatment protocols have created real risks for the reemergence of drug-resistant HIV, for example, and the rise of maternal and infant mortality. Critical disease surveillance systems for infectious diseases such as TB, in healthcare facilities supported by the US government are now closed, undermining early warning capacity for future outbreaks. The funding freeze has triggered mass layoffs, salary suspensions, leading to workforce depletion and widespread psychological distress among those still employed. Clinicians are now working longer hours with very few resources, often in environments that are contextualized by moral distress. Next slide, please. The economic and social implications are becoming increasingly visible. The sudden unemployment of thousands of skilled health workers has strained households and exacerbated poverty, especially among women who disproportionately occupy community-based care roles. The health system's contraction also risks destabilizing regional health security, particularly through cross-border transmission of infectious diseases. Civil society organizations that were once the engine of innovation and accountability in health governance are now under pressure to self-censor and de-risk. The cumulative effect, of course, being now the retraction of civic space and weakening of a right-based health programming. Next slide. This moment calls for structural reform. Kenya, my country, must prioritize domestic financing for health, including establishing an emergency health fund and greater integration of essential services such as sexual and reproductive health services, HIV services, and a national policy framework such as universal health coverage. But transitional planning is equally critical. The funding withdrawal was executed without timelines or safeguards, making recovery very difficult. Health systems, as we know, once destabilized, do not rebound with the next budget cycle. Rebuilding trust among partners, providers, and communities will require sustained commitment. The decisions that brought us here and having these conversations were made in capitals, but the consequences, as we've seen through our interactions and this study, are deeply local. Patients are waiting, health workers are burning out, institutions are straining. The path forward demands very bold partnerships, honest reckoning, and above all, political courage. Thank you for your attention.
Next slide, please.
Hello, everyone. The title of my presentation is Impact of the US Funding Cuts on HIV/AIDS in Nepal. Here, I would like to emphasize that though our impact assessment covered all aspects of health, including nutrition, but for this particular presentation, I'm focusing more on the HIV/AIDS in Nepal. We all know that Nepal was able to reduce HIV cases, positive cases, from 70,000 to 33,000 over the past 15 years. And this is basically possible due to the active contribution of INGOs and NGOs who have been working very hard in trying to bridge, to play the bridging role between the positive cases with the static clinics. And most of the clinics are run by the government in Nepal. Next one. Can I have the next one? Yes. Our study participants were comprised of the NGOs, INGOs, the government staff and the clinicians based at the ART clinics, and the Ministry of Health officials. So I have three major impacts, and this is the first impact. There has been a diminished role of the NGOs who are involved in the HIV prevention and treatment program. One of the NGOs whose main target was basically comprised of female sex workers and clients of female sex workers, and they were working for the past 2 years. They were disallowed to perform HIV prevention and treatment activities that included distribution of condoms, lubricants, and provision of PREP from the reduced amount of the fund released to the NGO post 90 days. Similarly, another NGO who have regained the funds in a reduced amount was also instructed to confine the activities only on saving life of the clients and also HIV testing. The prevention aspects such as condom distribution, condom and lubricants distribution, and the PRP were being stopped. One of the field-based project officers of an NGO working in the LGBTQI plus community was unable to retain the project staff as per the SOW. The project lead of this office lamented, saying that due to the limited scope of work, they are unable to track the new HIV cases, counsel such cases on safety measures, and bring them to the ART clinic. Next slide, please. NGOs have had to halt community outreach efforts, as I've just said. They have to stop community level screening and education, prevented follow-up work with the clients for HIV treatment at the community level. And these are some of their views when we talk to them. May I have the next slide, please? The second impact has been the rising risk of new untreated HIV infections. Now, there has been a growing fear among the NGOs saying that because they have been stopped to work, they have been asked to stay home, they are not able to screen out, identify new hotspots, and screen at the community level for possible, new cases, and then refer them to the ART clinic because they have been asked not to perform any work at all. So this has been one of the major concern with the NGOs who have been working on the HIV experiments in Nepal. Can you have the second slide, please? Next one. So these are also some of the perception of the providers, the NGO providers, when you talk to them. I would like to just want to read out that we cannot identify new hotspots of high-risk population and screening for possible positive cases. I'm sure that number of HIV cases must have increased considerably now. Unfortunately, we do not have any contacts with such new cases. Next one, please. Another important impact was the human and organizational cost. As we all know that staff were been forced to lay off due to closure of the projects. The clinics were run by the NGOs were closed, and those staff who remained in the clinics had an increasing workload. NGOs, especially the grassroots NGOs in Nepal, had a financial strain as they struggled to pay the office rent and the salaries of the health providers and outreach workers that they have recruited. Now, one of the NGO have said that everyone is suffering from mental health issues. They are saying things like, "Where will you get the job now? And what should we do now?" Next slides, please. Now, we have contacted some of the NGOs post 90 days of limited waiver, and these contacts were made by us through phone. We couldn't visit them at the clinics. This was basically to obtain the implementing NGOs' perspective on what has been the impact, because some of the NGOs have been receiving a limited amount of funds. For example, the EPICS project were allowed to resume HIV testing among the high-risk groups and linking them to ARD clinics and treatment support. However, preventive activities such as PREP, condom and lubricant distribution, STI prevention and treatment and awareness programs were being stopped. They have not been permitted under the funding. So NGOs program managers expressed their frustration for unsecured or limited period of assured funding post 90 days. They are not knowing whether the project will continue after 90 days, after the post 90 days, because some said that they have to work until September. Some said, well, you carry on, we will let you know as time comes by. So that was some of the a situation of insecurity created for the NGOs working on HIV prevention. Next one, please. So the key takeaways are basically like the loss of US funding has disrupted HIV prevention outreach activities. NGOs who have lost capacity to serve high-risk communities, they fear that the number of HIV infections must have soared in the past 90 days because they are not able to go to the community and link them to the ART centers. As you know that many of the HIV positive cases, including LGBTQI plus, have a social stigma. They are stigmatized to arrive at the clinics. They wanted a secluded places to get care and support from them. So thank you so much. If there are any other questions, I'm happy to answer them. Thank you.
Thank you, Dr. Taman. Thank you to Julia and Camilo and Anand for that powerful and clear sort of presentation to capture the weight of the impact. And I think Anand ended on a really important note that there's risk to disease surveillance and control moving forward, not just for HIV, but for many other infectious disease around the world. So at this point, I'd like to invite Corinne Karima to share her reflections from her purview, who advise donor, who advise organization on to take some reflection of this on the finding that were presented. So Corinne, over to you.
Yeah, thank you very much. So good morning, everyone. First of all, I would like to thank the organizer, so the Department of Population and Family Health at Columbia University, for the opportunity to contribute to this critical conversation. I know it's not easy, but we need to find a solution together. So I also want to acknowledge the excellent presentation we've just heard from Kenya, Nepal, Colombia. And I feel that they've just shown us the human and systemic impact of global funding shifts across countries and programs. So in brief, in my reflection today, I will just focus on 3 key points. The first one will be on the impact of the US funding, especially from PMI, as I've been working for more than 20 years in malaria, and then also discuss a bit some projected consequences of the current disruption, and with some specific countries example, in addition to what we have just seen in the previous presentation. And the second one is maybe to allude that why the US global health investments are not just an act of solidarity, but it's more strategic for the continent as well as for its global health security. And then the third one is maybe what are the lessons learned, because I feel that this is a moment that teaches us as Africa about the need for Africa to reduce its dependence on health and build a stronger and more self-resilient health system, as Juliet said. So for the first point on the impact of the US funding. So over the last 2 decades, when you look at the contribution of PMI as well as the Global Fund, because you know that the US was the most important donor, more than 37% on the malaria, contributing to the malaria funding. So this has saved over 10 million of lives and prevented 1.7 billion malaria cases. So we have seen remarkable progress, and this I'm sure has been also seen when we look at the trend of the burden of HIV and TB. But what is also scaring, the progress is fragile. So there is recently the Malaria Atlas project that warns that if the Presidential Malaria Initiative funding is disrupted across 27 African countries, we could see more than 14.9 million more malaria cases, as well as more than 100 additional deaths in 2025 alone. So, and this isn't theoretical, because program currently have already seen procurement delays, essential staff cut, as we have seen in the previous presentation, as well as breakdowns in community level delivery. So countries like, in addition to Kenya, Nigeria, and Uganda, to just mention this, are already feeling the ripple effects. So for instance, in Uganda, the health ministry has announced to shut all the dedicated HIV and TB clinic in response to the USAID funding cuts. Pharmacies that were exclusively supplying ARVs for treatment for HIV will also be closed, as well as dedicated HIV clinics that have helped to Uganda to reduce the infection rate from 19% in the 19s to 5% in 2024 as part of the plan funded by the US President Emergency Plan for AIDS Relief. So, we have seen that advocates as well activists, they've warned that the sudden closure of the service could lead to a spike in infection and stigmatize patients. And we have seen also that in Zambia. In Zambia, it's the same. The decision will impact Zambia access to medication for HIV, tuberculosis, and malaria. And this will affect at least a third of most of the public health system in Africa. So now, why US AIDS is an investment? It's not just AIDS. So global health funding is not. I believe that is not just a moral imperative. It's a matter of smart strategy. Many of the most serious health threats that have been seen to the US in recent years, or to the world, not only the US. So when we look at the COVID-19, when we look at the Ebola, when we look at the Mpox, most of these diseases were originated from abroad. So cutting support for disease surveillance in those countries where these pathogens are originated, cutting funds to strengthen laboratory system that will detect and identify the pathogen and help to really fund the appropriate treatment, or to cutting funds for outbreak response. I think that will increase the risks of global pathogen reaching America, reaching the US, reaching the world, and even having important spread of the disease that will remain contained. And by investing in global health, the US is also strengthening its own preparedness. It's building international goodwill, of course, but it's also foster stability in key region. And I think that those are really strategic safeguards. So we have seen also in the previous presentation that there is delay of treatment. So I'm currently in Namibia, where we are having an African HIV conference. And most of the country have shown that there was delay in the treatment. So, and you all know the consequences of delay in treatment. There is spread of drug resistance, and HIV is everywhere. We are moving, the borders are open. So there is also a risk of increased spread of drug resistance in the US as well as worldwide. So for the third one, I believe also this critical situation, it's a wake-up call. So there's needs to build domestic resilience. So of course, this crisis is revealing a hard truth for us in Africa. We have been too dependent on external aids, while the US, as well as the international support, has been catalytic. I believe this cannot replace the urgent need for African countries to diversify funding sources, improve domestic resource mobilization, and build long-term capacity. So the impact of PMI has had, despite being a relatively small part of the aid pie, proves that focused investment, when used well, saves lives. And we might now ask, how can we replicate that impact using our own resources and also be aligned with to national priorities? So to summarize, the US funding has delivered tremendous gain in the half, but disruption threatened to reverse decades of progress. And the continuing US investment is not only a gesture of solidarity, but it also protects Americans' own health and global standing. And we as Africans should see this moment as a pivot point, a chance to strengthen our system, to reduce head dependency and invest in long-term sovereignty and resilience. So I will just end with a note of hope. This is also a moment for us to explore new mechanisms for financing global health. For instance, blending public and private funds, leveraging regional institutions, and making every dollar go further through better targeting and accountability. So the response to this response can be more innovation, more equity, because we have seen disparities, and ultimately more ownership. So I thank you, and I look forward to the discussion.
Thank you so much, Corinne, and thank you for joining us from Namibia. Next slide, please. So I take chair prerogative, and I just want to build on what Corinne just said and really thinking a way forward. But I also want to hold space for how incredible, heart-wrenching the data from the country is. And our mission at GHAE throughout this period has always been really zeroing on the ground realities. So, we have a preliminary sharing of this data in early this year, and I make a call to action to donors who hold power and privilege. They should act immediately. And I will pick up on this discussion point with our panelists. But last Friday, the Gates Foundation had made bold announcement that they will give away 200 million by 2040. And maybe they have heard my call to action, maybe not. But I think immediately we really need to, while I think the job losses in Geneva, in New York City, in Washington, D.C. can be seen as unstabilized. But the data and insight on the impact on the grounds must be the starting point of global health reimagination and investment. And the support and continuation of the life-saving services that Camilo, that Julia and Anand and Corinne talk about must be immediately course-corrected if donors gonna really kind of save the sector and ensure that data and storage reach key decision makers. So there's some question whether we are sharing the story with policymaker. We're working with several people in DC to make sure that this reach the Hall of Congress. But I also call on you, our audience. There's 200 something of you joining this call. We will share all of this with you. Make sure that you can talk about this. Every voice matters. And then I want to pivot to the strategy moving forward. We need to really work together, right? We can have this silo kind of disease prevention and eradication approach, but really think about system integration. HIV, sexual and reproductive health, maternal health, primary care need to be squarely integrated. And we need to invest in resistant and resilient strategy and cross-sector collaboration that we can counter the opposition from misinformation that is happening in country to misinformation that happening globally. And then maybe this is a chance for donors to really and government to really invest in the capacity strengthening. People gonna solve and innovate on the ground and solve their own realities. So instead of focus on disease prevention that we have done for decades, we need to invest in system and people who will innovate and weather crises. So some of our speakers have talked about this, but government must prioritize investment in community health and primary health system and mobilize diverse funding, especially domestically, through government, private sector, and private sector leveraging their scale and their impact. And philanthropic donor had an obligation to really bolster up civil society. Julie talked about how civil society is being censored or they are self-censoring because they are relying on those funding. And the possibility for cell-to-cell partnership could be reimagined now, and I think it could be flourishing given the disappearing of big aid. Because, foreign aid reduction is not a blip. It has been a 20-year pattern. What we've seen in Australia aid, in UK aid, and now what we're seeing in US aid. So I will move to panel discussion. And the first, I know Camilo will have to, this is we're tuning into like global health in action here. And we want to kind of pick up on your remark because you have to fly very soon, Camilo. So I just want to really think about this, pick up on this idea, both that you have this compounding impact of the reverse migration that is experiencing. So how are you thinking about your program, your partners, and adapting to that? But also, what is your call for action from local government, from the private sector, and philanthropic sector, so that you can end and then run for
Yeah,
that?
thank you. Well, I mean, this is the type of questions we have been asking ourselves the last couple of months, honestly, how we can just to maintain or trying to guarantee that we are responding to the most vulnerable people, having in mind or just to challenge this response with the current financial situation. And basically is, as I was mentioned before, the crisis is still here. The migration crisis is still here. We have like a two or three type of population who are still in need. And this is the call, basically, I want to explain. The first one, we have the people in transit, the ones who are in the reversal movement. They are arriving to this country without any capacity to cope with their daily life. And this is one of the most important things. They're not having the capacity to pay a rent. They don't have the capacity to apply for a job, or they don't have the capacity to access to a basic services as a health, education, because they are arriving without any documentation. This is one of the cases. The other one is about the people who have a TPS. Colombian government opened a temporary protection status for refugees and migrants, mainly from Venezuela. And they can't just do their services that are trying at some way they're kind of guaranteed from the Colombian government. But the ones related with the access to a formal job, the access to a specific medical treatment are not fully guaranteed. It means that they can access to the emergency, to an urgency, but in terms of mental support, and health support, they are not receiving all services required as a long treatments, long-term treatments. And the third one is the population who are using Colombia in this case as an extended transit period. It means they are not trying to cross the country in a few days or weeks. They want to stay for a couple of months, trying to reach some money, and then trying to just to keep the trip to the south, trying to just to come back to Venezuela. But basically, the call or the issue I want to highlight is we know that, and this is related with one of the questions on the chat, how we are trying to diversify the funding, and it's clear that the amount and the size of the support of the U.S. government is not easy to replace immediately, and this is clear. It is not easy. I mean, it's not from a one day to another, but we can start with the interest and the support from in this case, from the European countries, European Union, private funding, philanthropies, and all these organizations, they're now to identify that with this gap, we are increasing the crisis. So I'm trying to just, with the reductions, with the cuts, with the freeze, we are, maybe from the US perspective, they're not solving anything. We are increasing the crisis in the countries where we are providing this assistance. And maybe in an increasing process, trying to just to guarantee or to increase the resources to provide some type of this assistance to the countries, to the people who are now as migrants and refugees in these countries, could be an option. It's not easy. As I said, it's not a magical potion that we will have this on one day to another. But basically, what I try to just to highlight is we have to maintain the response, and also have to keep strengthening the local capacity and the local capacity from the local organizations and local authorities as well, trying to just to reduce the impacts of these cuts. Over to you.
Thank you, Camilo, and thank you for joining us. Safe flight. Thank you. I appreciate you. So I think I want to pick up on this idea that Camilo talked about on the informality of migrants, right? And Corinne, Karima, and Anand, I know that in sub-Saharan Africa, for instance, 50% of people do live in informal settlements. So they have that informality identity, which prevents them from having access to care. And I want to, and in Kathmandu as well, Anand, there's a huge informal population who come from rural to urban center for job opportunity, for better livelihood. So they don't have that access. And I want to really think about what are your perspective in thinking about how is their life being impacted? What can local government do to, because I can imagine they are the first to have less access to care and to prevention opportunities. So maybe Julia, I'll start with you and Anand and then Corinne.
Thank you. Why? You're absolutely correct. From our study and our findings, the people most affected were the people in hardest to reach areas, especially those living in informal settlements in urban areas. And the crisis has made it painfully clear that we must rethink the architecture of financing nationally and globally. Many of the partners argued that the freeze collapsed the scaffolding around which the health ecosystem has been built. There's no contingency planning, there's no transitional mechanism, there's no risk mitigation strategy in place. A good example is one partner who mentioned that after the funding freeze, not only were they not able to provide services, but the referral network that they had with their implementing partners also collapsed, compounding the disruption of these services. So moving forward, what can we do? I will start with the funding part. First, we should philanthropic and bilateral partners should embed transition strategies in all long-term investments, because we did not have this, and that is why we are having these problems that we're having right now. Funding frameworks nationally and with donor funding must include shock absorbers, emergency buffers that allows the system to adapt, to recalibrate, and not collapse when policies shift by the strike of a pen. Governments like ours, the Kenyan government, African governments, also need to confront the reality that there's an over-reliance in external aid. They need to rethink how health is funded. They need to meet the commitments of the Abuja Declaration and get to the 15% that they committed to. it's a wake-up call to increase domestic health budgets and treat health as a non-negotiable public good. And allow civil society also to engage in this space without fear of being castigated, without fear of speaking about these issues that are now considered not, they cannot speak freely on because of fear of, not having funding in future. The self-censoring that is going on at the moment, not only in Kenya, but across the continent. Yes, so that's my quick response to you, Thoai.
Thank you. Anand?
Kathmandu do have higher level of internal migration, but these populations are to some aspect, have a semi-permanent type of settlement because people like to come to the country's capital to start their, career and education. Unlike in African countries, we don't have much of the floating population. And from the health perspective, irrespective of whether you are a temporary immigrant population or not, the services, including reproductive health services, are free at all the government health sectors, government health clinics. Only in private sector, like you have to pay for that. So the issue about not able to seek care are generally because of the lack of awareness and their access to the service, where to go. So here the role of the NGO and local NGO and CBOs are very crucial in linking. As I said, they play as a bridging role in trying to take them, provide them with the education, awareness, and then take them to the right place for care. So I think at the moment, that's my answer.
Thank you. Corinne, do you have any reflections on this?
Yeah, thank you very much. So I agree with the previous speakers that it's really important that we as Africa, we need to rapidly adapt to the funding disruption. And what we have been, for instance, doing with the Africa Kwanzaa Impact, it was our immediate focus has been to protecting the integrity of core services, especially commodities, surveillance, and community delivery. So trying to support countries to, first of all, reprioritize intervention using subnational burden data, as well as try to see how we can advocate for increased domestic financing. So for instance, 2 weeks ago, we have convened a policy dialogue with parliamentarians and ministries of health and finance for 15 countries, and they have launched what they call the Coalition of Parliamentarians Against Malaria. So they really commit to advocate for the increase of domestic funding. And of course, it's really important that Julie said that we need to increase money, we need to increase the health spending as well as funding. There is the Abuja Declaration, but do we really need more money for health, or do we need more health for money? And I think it will be very important for us to streamline operational strategies to avoid waste and duplication, and then efficiency and targeting. It's really very important. So I believe that we need to reimagine the architecture of global health partnership, and especially we cannot afford this silo investment or over-reliance to a single funding stream. So we need really bold, coordinated, and country-led financing strategies. So in addition to the domestic funding, I think there is also the private sector that needs can be brought in to maybe be involved in co-financing platform, investing in innovation, because I believe that the private sector in Africa, not only we have more than 60%, for instance, of malaria cases seeking healthcare in the private sector, but we also have some money that we can get from the private sector in funding the health. And then, of course, the private philanthropy. So we welcome the increased funding and the bold decision of the Gates Foundation. And I hope that this is be taken as an example for others to also step up. So I think that's what I can say for now. Thank you.
Yeah, I agreed. I think I hope that open space for other philanthropic donors to be more. I know there's political sensitivity in the United States around foundation and etc. But I really believe close dialogue across foundation is critical. I also want to kind of say something really important. I think all of us who work in this field feel like foundation tends to constantly re-strategize. And I would ask that this is not the time to re-strategize, but this is the time for immediate action as we can keep the stabilization of health services on the ground. And then we can really think about what is the next strategy moving forward. I want to pick up on this idea around private sector. I think, in many ways, in contraceptive development, in HIV, I think many of that sort of infectious disease have really leveraged the private sector for investment because they really see one is that it brings when they have a healthy population, they can invest in that population to generate goods, to increase GDP. And I just kind of want to understand from all of you have to call for structural reform. And I think that's something that perhaps many of us haven't really kind of leveraged this public-private partnership in a bold way, not in kind of because there's company that invest in here and there, but they don't really kind of invest in a bold way. What do you think of the strategy should be in kind of working with local governments and talking to local private companies, but also international company that want to invest in sub-Saharan Africa, that want to invest in Asia? Yeah, I just want to open up the floor, and any three of you feel free to comment.
Thank you, Troy. Maybe I could begin, and then I'll let the other speakers also engage. I do agree that the private sector is an important actor to engage in public health because they have the infrastructure, they have the capacity, they have the financial muscle that may not necessarily be available at certain times. For example, at this time when we're having this major crisis, we've seen collaborations with private sector actors moving the needle in terms of access to commodities. For example, there are very fantastic programs in Africa where some organizations have partnered with private actors who are in logistics and supply chains, and they use drones and such like innovative mechanisms to get medicines to people in the remotest places that you can imagine. So I do believe there's a huge potential to leverage on public-private partnerships. But then again, with having in mind that provision of equitable, rights-based health services must remain anchored in public systems and rooted in community, engagement, and community organizations. Private actors can supplement, but they cannot substitute. At the end of the day, the ball is in the government's court. Public health is what can remedy the crisis that publicly funded health systems is what can help remedy the crisis that we have at this moment. Over to you, Thoai.
Thank you. We're closing in very quickly, so I just want to invite Corinne and Anand to have like brief 30-second remarks before.
May I start?
Yeah, please.
Well, this particular impact assessment of the global funding cuts by the US government was confined to obtaining the provider's perspective and the NGO's perspective. We have not seen the perspective from the beneficiaries. So in Nepal particularly, this impact assessment did not cover the benefits perspective. So it's important now as a next step to triangulate the information that we have, the rich information we collected from the NGOs and the service providers, both at the government and the non-government sector, by going to the community and talking to the beneficiaries to understand what has been the change in their care-seeking behavior. Has there been any change? Or what is the level of default from taking their regular life-saving medicines? Do they know that where they can go for free services in the absence of the NGO who are supposed to play the role of a bridging population? And do they perceive, what is the level of perception regarding the risk that they have for acquiring an infection, either they be STIs or HIV or any other, life-threatening diseases? And then what happens to them if there is a severity of the problems for HIV or STI-related problems? And most importantly, hope it doesn't occur, what has been the morbidity or mortality, particularly death related to a curable, preventable disease. So that type of research is needed to complement or to triangulate these findings from Nepal, and maybe it's applicable for Colombia and also for African countries. And we hope that there will be some donors, private donors will come forward to you and to, support you for this type of community-based, beneficiaries perspective research. Thank you. I'm a research scholar, so that's why I'm influencing on the research.
Yeah,
Thank
you, Anand, and thank you for that call to action. I must say that this effort have done with very little resources from Colombia and our partner without any donor support. And I think you heard it from Anand. I think the community really, we need to engage with community and understand that on the ground. And Corinne, you maybe 10-second last call to action from you.
Yeah, thank you very much. So mine is let us use this disruption as a springboard, not to retreat, but let us reimagine. Let us fund smarter, plan together, and put countries and especially communities in the lead. And as Julie said, it's time to invest in resilient system, efficient delivery, and sustainable financing. And we need to act now. Thank you.
Yeah,
And
thank you so much.
let us turn uncertainty into opportunity and dependency into domestic strength. Thank you.
I appreciate you all. Thank you so much. And I love that we are able to center the country needs today. And I really believe that, in even we are operating in this tense time, international collaboration is the way to weather this crisis. So my call to action is that we shouldn't back down from any international collaboration. And I hope that our fabulous panelists today have demonstrated what powerful data we can collect with our very little resource in a quick time. So thank you to our panelists. Thank you all for joining us today. We really appreciate you. Stay tuned. We will share research brief, papers, and data so that you can use in your own work as well as from advocates to research to programming and to design better policy and programming for the population on the ground. Thank you, everybody. Have a wonderful day.
Thank you. Thank you. Bye-bye.
Bye. Thank you, everyone.
Thank you.